Hi, everyone. My name is Mahi Chanpura, and I'm currently presenting from Springfield, Illinois. During my freshman year of high school, with guidance from my mentor, Danielle Kim, I conducted a research project focused on thyroid cancer, exploring not only its types and prevalence, but also comparing emerging therapeutic strategies with conventional treatments. I chose this topic because I was particularly intrigued by Georgetown University's summer research course for high schoolers that I ended up taking before starting high school. One of the final modules covered thyroid cancer. After completing it, I found myself diving deeper, Googling questions, exploring case studies, and becoming fascinated by the variety of treatment strategies available. I began asking questions, like with emerging treatments available, why aren't we combining them more often with traditional ones to move beyond a one size fits all treatment approach? That curiosity launched my research journey. I focus on comparing key treatments for thyroid cancer, specifically thyroidectomies, radioactive iodine or RAI therapy, various ablation therapies, and combinations, like RAI after surgery with or without adjuvant therapies. I organize my findings as a concise comparison of recent studies to enhance clarity and accessibility. Let me now take you through my research. Before understanding treatment options, it was important to first understand the different types of thyroid cancer. The four primary types include papillary, follicular, medullary, and anaplastic thyroid cancer. To provide a better comparison, let's understand that papillary thyroid cancers comprise 80% of all malignancies and are the least aggressive, while follicular thyroid cancers represent 12% of all thyroid malignancies. Both papillary and follicular thyroid cancers are differentiated, meaning that they have staging systems. Furthermore, papillary thyroid cancer predominantly affects women and typically affects between the ages of 30 and 50. It has an excellent prognosis due to its slow progression and high treatability. Follicular thyroid cancer often occurs in regions with iodine deficiency and typically affects middle-aged women. Furthermore, medullary thyroid cancer represents 3 to 4% of tumors, and anaplastic thyroid cancer makes up less than 2% of thyroid cancers and is the most aggressive. Medullary and anaplastic thyroid cancer, unlike papillary and follicular, are not differentiated, meaning that they do not follow standard stages. In addition, medullary thyroid cancer tumors secrete calcitonin, a hormone which serves as a tumor marker or indicator that the tumor is not papillary, follicular, or even anaplastic. For context, the thyroid is a quarter-sized butterfly-shaped endocrine gland located in front of the trachea. Thyroid cancer, though relatively rare compared to other malignancies, represents the most common endocrine-related cancer. While the majority of thyroid nodules are benign, there's always a potential for them to develop into a malignancy. Thyroid cancer is 3 times more prevalent in women than men, and Africa is projected to have the highest increase in thyroid cancer prevalence and mortality rates. African regions, along with other regions measuring low on the Human Development Index, or HDI, have higher mortality rates due to discrepancies in accessible care and other environmental exposures. However, in 2020, low HDI regions represented 73% of overall worldwide mortality from thyroid cancer, an increased number from 66% in 2018. This puts patient populations in low HDI regions and the African region at a higher risk for thyroid cancer, with females at the highest risk. Fortunately, treatments and therapeutic strategies have advanced in recent decades, showing promise for improved therapeutic outcomes. After establishing all of this, I moved on to define the treatments I'd be comparing most in my paper. These treatments include ablation therapies, radioactive iodine therapy, and surgical treatments. Thyroidectomies and lobectomies all fall into the category of surgical treatment. They involve the removal of a lobe of the thyroid gland, which is usually used for smaller tumors, or the whole thyroid gland, which is used for more advanced types of thyroid cancer or larger tumors. Next, radioactive iodine therapy, or RAI therapy, works by allowing thyroid cells to absorb radioactive iodine, which leads to targeted cell death because the thyroid gland is the only gland that absorbs iodine. Finally, ablation therapies include many types of ablation, such as radiofrequency ablation, laser ablation, and microwave ablation. These methods use heat delivered through the tumor through high-frequency electrical currents, optical fibers, or microwaves to cause tumor necrosis. To specify, radiofrequency ablation, or RFA, uses high-frequency electrical currents. Laser ablation uses optical fibers, and microwave ablation uses, you guessed it, microwaves to decrease tumor size. In the finale of my research paper, I compared surgery, laser ablation, and RFA, focusing on outcomes like complications, recurrence, cost, and survival. I found that surgery had higher rates of complications, blood loss, procedure time, hospital stays, and recurrence. On the other hand, RFA had higher treatment costs and was associated with slightly higher recurrence-free survival rates, but showed slightly more disease progression and persistent lesions over time. Complete or tumor disappearance was also noted in 71.4% of the RFA-treated group, whereas complete or tumor disappearance was also noted in 71.4% of the RFA-treated group, whereas surgery removes all visible cancerous tissue. So complete nodule disappearance isn't exactly expected or measured the same way as an ablation. In regards to laser ablation, it had similar outcomes to radiofrequency ablation. For example, laser ablation had a 71.0 nodule disappearance rate, which is only 0.4% lower than the observed RFA nodule disappearance rate. Furthermore, the complication rate in the laser ablation group was slightly higher than the rate in the RFA group, but was also significantly lower than the complication rate of the surgical group. Radiofrequency ablation and laser ablation, both forms of thermal ablation, were shown to be effective in treating papillary thyroid cancer nodules under 5 millimeters. One study even concluded that RFA was a safe, effective alternative to surgery when treating unilateral multifocal papillary thyroid microcarcinoma, a surprising result that underscores the therapeutic potential of ablation therapies and suggests an alternative treatment strategy, helping move beyond a one-size-fits-all treatment approach. In conclusion, thyroid cancer is an increasingly prevalent condition, and with more emerging treatment options, comparative studies like these will play a key role in guiding personalized care. My goal through this research is also to reinforce the effectiveness of standard treatments, while also emphasizing the need to explore and validate alternative therapies, such as ablation, especially in carefully selected patient populations. Thank you for listening to my research project presentation. Once again, thank you to my mentor, Daniel Kim, for guiding me along the way and answering my numerous questions. This is Mahi Chanpura, presenting from Springfield, Illinois.
Great job, Mahi. Really informative, super interesting. Great. So I have a few questions. Again, anybody else, feel free to throw in the Q&A if you've got some of your own. The first thing, this is not my area of expertise, so can you tell me can you explain more about differentiate it and when something doesn't follow standard stages, what that means exactly and how those are different?
So follicular and papillary thyroid cancer are differentiated, meaning that they have stages, stage 1, stage 2, stage 3, stage 4. But since medullary and anaplastic thyroid cancer are so rare to get, they don't have those staging systems because they're already, number one, so lethal and they're already so rare. So they don't have the staging systems that follicular and papillary thyroid cancer do.
Got it. Super clear.
Thank you for the question.
And then, so of the treatments you've described, are they kind of isolated by the different types so far? Like, is it typical that people with papillary will go one treatment route compared to another, or is it kind of similar across the board how treatments are approached for the different types?
So I would say that it's different, but it's different really according to tumor size. So ablation therapies have been proven more effective with smaller tumors, whereas surgery followed with radioactive iodine therapy has been proven more effective for larger tumors. So I would say that yes, they are isolated, but from my expertise, I'd say from tumor size instead of type.
Yeah. Great.
Thank you for the question.
Of course. And then tell me, what's next for you and this interest? Are you gonna kind of continue exploring this, other things? What's next?
Yes. So I want to be an oncologist when I'm older. And so I really enjoyed this research and I'd love to conduct more. And this was a great way for me to get my feet wet and with research and understand how this all works. And now that I understand like the basics of a research paper, how to synthesize information, I'll be able to carry that forward into my high school career. And I'm going to try and get internships where I'm able to also conduct more research and possibly use all of this I've learned to the test.
Yeah, that's awesome. Great. And that's our hope for you and all of our students too.